There was a lot of discussion about the discontinuation of the ECMO in the morning, and we were waiting for this lecture. I think we'll have questions. First of all, I'd like to ask Dr. Ramesh, the first lecture on the about the awake ECMO in role of awake. I'm not able to understand you. Is it you were trying to say that awake ECMO is better, or you were saying that?
Yes, I mean, at least as far as the COVID cohort is concerned, our experience has been that awake is better than keeping them ventilated. So usually the kind of narrative of these patients is that they've been prone, they are excessively sedated, and they have muscle relaxants in order for the proning to be effective. Usually what happens is it is at this point that they are referred to us. And there are issues about how you can put them supine and then you have to go on ECMO. But usually when we do that, we find that it takes a few days for them to wake up. The general approach to these patients was you continue to give them some level of sedations even if they are awake, and you keep them fully sedated even if you remove the muscle relaxants and keep them on ECMO. There are many reasons why units may choose to do this, especially abroad in the West. They're afraid in COVID of communicating a lot of high viral load to the nurses. But the most important reason why they do this is because they do not have enough staff. This takes a 2:1, 2 nurses is to 1. And at least for every 6 patients, you require a roving perfusionist, and for every 12 patients, you require a senior perfusionist to be on there all the time, along with 2 to 3 dedicated physiotherapists per shift, or at least you should have 2 physiotherapists on each shift in the morning and 1 in the night, because these patients will require quite a lot of physiotherapy, and by the time they're finished, it takes almost about 18 hours by the time they go through one circle of patients. So therefore, the manpower is the main issue that most units opt for not keeping patients awake. The second
I'm sorry. Yeah. I think the discussion will go very long. I just want to cut short here that you want to say that you are not putting you are putting the patients awake here because you have enough manpower, while they are not putting they have manpower.
I wouldn't say that directly, but there are multiple reasons why a unit might opt for one or the other. But if you do have all of those things, I think awake is, in my opinion, preferable to being sedated.
Awake to start with, or awake that everybody consensus was in the morning that yes, once you have, after a couple of days, you need to get them out of the sedation and let them be breathing spontaneously, because to avoid the myotrauma and other things.
That's right.
But
okay, initiating the ECMO awake is not necessary, but most of the cases we do not have those kind of patients who transit from NIV to ECMO. The majority, if not all of the patients, have already been ventilated. So yes, initiation is not a big criteria for awake, but immediately after going on ECMO, we would try to extubate them.
You know, one of the discussions we need to have, as I said, increasingly now with this pandemic, ECMO seems a more mature therapy for select patients with ARDS with or without COVID, is that it's our opinion that a lot more patients would survive ECMO if they had not, pulse steroids and, all those MABs, and they come loaded with bacteria and fungus in the lungs. So I think at some point a more broad-based discussion with medical specialists is needed to define clearly the role of ECMO and in the natural progression of the disease, and at what stage it should be initiated. Perhaps I also had the impression when I first saw your title that you're suggesting patients should be put on ECMO without being intubated.
No, that was, I think the more important thing is to keep them awake during the maintenance phase and during the wean phase. Rather than initiation, I think we rarely ever get patient who's on NIV who's awake and they say go on ECMO. Most of them are intubated anyway. So it's just a question of extubating. To answer your other question, I think there is already some data, even with respect to ECMO, is that tocilizumab does confer a survival advantage in terms of lung recovery, although it's associated with much higher infection rates on ECMO. So how these two trade off against each other is something that we have to see, but definitely lung recovery when initiated early for tocilizumab is definitely useful. So, pulse steroids not so much.
Yeah, I think what Paula raised the issue is you are putting the patients on ventilator, then you are putting on ECMO, and many days they are microcurium, earlier steroids. So you are trying to prevent the volume trauma, but at the end of the day, you produce myotrauma. You are deconditioning the diaphragm, and the patient can't, even when the gas exchange looks to be okay, they are not ready to breathe. So that's bringing them back as early as possible is the aim. But how quickly, that's what is.
I have a question to the anesthetist.
Excellent talk.
Sorry. Do you think it's a time we can relook at the iron lung, the old physiologic negative pressure ventilation to maintain the muscle in this patient? Because
yes, I think
because there is a report in which a 70-year-old
yes.
patient is with polio still alive with iron lung.
Yes.
I think that was widely circulated.
As an alternative to going on ECMO, is that what you're asking?
As an alternative to being awake, or rather than non-physiologic positive pressure ventilation, which was primarily designed for a short period
Yes,
of...
I think one thing the consensus emerging is that invasive positive pressure ventilation is harmful.
Correct.
Beyond even a very short point. I think the ELSO data clearly suggests that beyond 5 days itself, there is a divergence of the survival curve. Beyond 7 and 11 days, it's fairly significant. So the earlier you get them on ECMO, definitely the better. Whether transitioning them from that to a negative pressure,
are the ventilators available, or
I don't know.
something
Yeah,
which
but
we can
it's
look into
definitely
it?
looking.
See, all the iron lungs have been used only those where the lung is not involved. It is only the muscular problem, and it is very good if you have a muscular problem. If you had a lung problem, it is useless. It is not going to help you.
Well, I think that's you rightly said. The reason why people wanted the patients to be breathing spontaneously is that they should ventilate their perfused lungs. The moment you start put them on positive pressure ventilator, you are ventilating their non-perfused lungs. So the BP mismatch. That's why the moment you put on ventilator, you will find a patient who was maintaining 90% saturation, he will maintain only 50% saturation. So I think that you have a reason to say that let them be spontaneously breathing, and then take out the carbon dioxide and give the oxygen. But the issue is when you are giving ECMO in a awake patient who is inflamed lung, will you be able to prevent the volume trauma which you want to prevent? Because they will still keep on breathing fast, because the inflammation is causing them to breathe fast, not only the hypoxia. Is there any evidence for or against it?
I think that's why some people use steroids. I mean, you talked about pulse steroids, but even other steroids to reduce the inflammation, so that the reduction of secretions all have to go hand in hand along with the ECMO as well. So it's just coming on ECMO and spontaneous breathing is alone not the solution, but all of the other things. So that's why I think the stoxluximab appears to improve lung recovery quicker, although they cycle through multiple infections. I didn't have the time to show that data independently.
See, Dr. Paul, one of the things which we faced initially when we transplanted this patient was significant muscle deconditioning, and the post-transplantation period was extremely difficult. So how do you sort of assess to make sure that they are adequately conditioned before you go for transplantation?
Yeah, so one of the things is if you give them this targeted physiotherapy, you know for a fact what they can do, what resistance on the leto they can go up to, and also in terms of the breathing, what's their level of spirometry if they're not tracheostomized. Or you can have a reasonable idea about their lung mechanics even if they are ventilated to some extent. In general, you will have some level of critical illness, myopathy or neuropathy in these patients. This is even independent of COVID patients going to lung transplants, or even other IPF patients who have been on steroids. It is a challenge, but in the majority of them who have been awake, it is far better than when we have taken them up ventilated as in the past. You can kind of have a feeling which patients will do better. The ones with better lung mechanics and diaphragmatic function, as you mentioned, is a single important feature. I think
Dr. Pubani, please.
Well, thanks for the excellent talk. The main advantage I find in keeping the patients awake is keeping the communication going with the family. So that gives a lot of satisfaction for the families as well as for the patients. The other point is explaining to the patient about the phase they are going through, how critical they are. It also helps in keeping the ECMO doing and in their recovery as well. I understand at some stage they have to be intubated, And in COVID situations, I totally agree with you. We don't want the staff to get contaminated as well. So you can take the decision on that. One question is about the multiple comorbidities you mentioned, in the complications you mentioned, that could be related to the multiple comorbidities as well, not only being awake.
Yeah, I mean, whether it was awake or not, you would have had those vascular and other bleeding, but when they are awake, it adds an extra dimension. If you want to take them to theatre for a retroperitoneal bleed, you got to tell this awake patient, we're going to take them to theatre and then anesthetize them. So this adds an extra layer of, as you say, communication with the family, but it also helps because they do know what's happening, and all the other ethical issues that Madan discussed are far more easier to deal with in this situation. And as far as going for transplants also, it's certain. I'm not saying that this is the only way to do it, but we have only sedated and done patients prior to it in the past. In this, we have had a greater learning experience, and we find that this may also be helpful, not in all patients, but in the patients in whom they are able to come and do it along with you and cooperate with it. It's very, very, very useful.
I think you wanted to touch upon the capital weekly about the carbon dioxide production.
Yes. Yes. So at least as far as COVID is.
I mean, you wanted to say that once the ventilator is able to take out the carbon dioxide more, that means the lungs have improved. That's what you wanted to say that?
That's exactly right. No, what we've seen in these COVID patients is that when during the recovery, the oxygenation appears to improve significantly enough to come off, even though the carbon dioxide is borderline. If you use the normal criteria of end-tidal carbon dioxide and the carbon dioxide and the gas, a lot of them appear to be fairly well compensated and they come off. Invariably, after a day or two, when they've done physio or they have some pain, they slide back to the point where the pH goes down. On at least 2 occasions, we have had to go back just for carbon dioxide removal. This extra layer of using volumetric carbon dioxide to wean, if you have the criteria of more than 48 hours of clamping and the volumetric carbon dioxide not coming down below 200, or at least half of the expiratory tidal volume has carbon dioxide. For example, if the expiratory tidal volume is 400, your volumetric CO2 has to be 200. We have found that none of them had to go back. Even though their carbon dioxides were also high, they did not end up with the criteria to go back on carbon dioxide removal. No, this is something we learned only in this time.
I didn't understand the 400, 200. What you were showing was that minute carbon dioxide production. Actually,
yes.
What we are concerned is the improvement in the dead space. That will be obvious from the decrease in the requirement of the minute ventilation. So the moment your minute ventilation requirement starts coming down, that means the lungs are a little better than before.
Yes.
Otherwise, the carbon dioxide
they
production
are
is the
getting
same.
better, but you sometimes end up just keeping them, even though the oxygenation is better, just for the sake of borderline carbon dioxide. So who are the ones borderline carbon? These patients, carbon dioxide don't get better for weeks after that. So up until that point, you don't want to unnecessarily keep them on ECMO. So to get them earlier, I don't know if Dr. Poponi wants to add at the point of volumetric CO2. This is something that we only introduced at this particular time. We have found it quite useful. So.
Sir, I have a query for Dr. Madan.
Yes, please.
Sir, a patient on ECMO for more than 1 month or 1.5 months, and for financial reasons, sir, any patient on ECMO for more than 1 month or 1.5 months, for financial reasons, suppose the family cannot afford it further. So, what is the stand for the legal point of view in those cases?
So, legal point of view and financially, that's what we have to counsel them before. Well, what is the finance, the controversies and other things. To some extent, we can do this fund raising and other things and all. So, crowdfunding and other things. Once you have exhausted all the money and then you are left with no other things, and then how to go about is you have to ask the family about this DNA and DNR, or else ask them to take to a center where they can manage with their family physician or something like that. That's all we can do. Otherwise, legally you can't stop the mission, and you can't, if they have to come for a DNA DNR. If they don't come for the DNA and DNR, then somehow the counseling should go on. And as I told for my third patient, you have to maintain a legally acceptable hemoglobin, legally acceptable protein level and carbohydrates, and then manage and let him go.
So officially I think we cannot do, but as you said, the legal values
unofficially it will not be told here, it will be told outside. So unofficially also you should not supposed to tell here, right? That is a basic.
Dr. Madan and Dr. Paul.
Ultimately, the question will be answered by the hospital management. Okay, if they want to keep this running, if you are fine, ultimate questions has to be answered by them. Okay, so that is the thing. The ethics committee should be there. You encourage them for the crowdfunding, because crowdfunding has become a very good ethics way out today nowadays, and people are donating those things. You make your the appeal in your Facebook page, in your Twitter. So make them this thing. So try to do that. We are all falling on that trap every day, every point. You are not the one only, and we are just trying to manage like this. Nothing. So one thing, sir, I'm just asking.
Thanks, Arpan. This is a very right point. When I say the ethics committee, put the ball in hospital's court. That's what I meant. Okay. So please.
One question, sir, Dr. Ramesh. Just contrary to your this thing experience, we found whenever they are getting awake, this kind of COVID patients, their respiratory rate goes up, say 40, 50, 60, and there is a term already came with this silly, spontaneously induced lung injury. His tidal volume might be 35 and he's breathing at 60. So at what level you are accepting those things? We know a lot of esophageal negative pressures and all this. We don't measure all of them. So at what level you are cut? What is the cutoff of your respiratory rate, and what is the thing? Because like this patient is not very comfortable.
Yeah, you're right. I mean, I don't think you should allow them at great tachypneic levels, because patient discomfort, if the patient is uncomfortable either because of tachypnea or excessive secretions, because excessive secretions, they may, even if you're not able to get it out, and some of these patients you'd find that when they're in the ET tube, against gravity the secretions will be coming, especially secondary infections. Those patients, when you extubate, they have the sensation of suffocation, even though you keep. These patients should not be managed awake. Absolutely not. But we don't have a cutoff, but around about 35, they're usually comfortable. Beyond 40, they start to get uncomfortable. Sometimes you just allay their anxiety, or you give them anti-anxiolytics and use a whole lot of other drugs.
3-4 anxiolytics.
Yeah, and they, most of them appear to this thing. But if we find that they're not, and as you say, they are feeling the sensation of suffocation or breathlessness, then we have to.
I think we can continue our discussion at the tea.
Okay, sir. Thank you.
And thank you very much for the excellent presentation, and thank you organizers for being part of it, letting me as part.